All right, Dr. Rob, thanks so much for joining me.
Thanks for having me.
Okay, so I discovered you online like everyone else does. And, I had seen breast implant illness clinically, but I hadn't found anyone like you that was actually specializing it and actually doing the hard labor that I'm not smart enough to do, which is the removal of these things. So, can you give us the story? I'm sure there is one. You had a host 29 weeks ago. So I don't know how many you've done since then, but one of your Instagram posts, May 7th, it said, as of that week, you had performed 1,498 breast implant removals.
Yeah, we're a little over 1,800 now.
Good Lord. And do you think it's an issue of increasing toxicity on the planet, why this is happening more, or is it just a larger awareness of this issue? I mean, what the hell's going on? Because you didn't hear much about this a decade ago.
Sure. So my background is in oncologic reconstruction, mostly in breast cancer, sarcoma, and head and neck. So when I started practice in the '05 kind of time range, we would do reconstruction for breast cancer after mastectomy, either using a breast implant tissue expander and then convert it to a implant that was permanent. Or my niche was to take the patient's own tissue and do a natural reconstruction of the breast mound using microsurgical technique, and that was called a DIEP preflap. And so those were very time intensive operations. So I really didn't have a a significant amount of my practice time to devote to doing implant based reconstruction because around the country, in the United States at least, in the communities that are, say, smaller than urban areas, we'll say under a million, even smaller, that would be the predominant technique used to perform a breast reconstruction after mastectomy because a plastic surgeon in that community, um, they would have the training to do that. And if you were trying to do what my niche was in microsurgery, you would need a lot more resources in terms of the operating room, just equipment and staffing, and then monitoring in the wards and the nursing staff and everything. So it was more of a medical center type treatment. So that's why you'll have predominantly more women with implant-based breast reconstruction after mastectomy. And then, of course, on the cosmetic side, there's two big bumps. One after, we'll say after the age 18, under 25, and then if someone's done having children and they have had breast deflation or SAG or what have you, there'll be a bump then, and we'll say that's 35-ish. So those are the predominant times you would see breast implants placed. And then is early in my experience, I've had people have trouble with capsular contracture because of the number of operations breast cancer patients have to go through. And I would tend up removing those sometimes because patients were uncomfortable and they had injury from treatment or therapy, radiation therapy, et cetera. And so we would remove them, and that would give the patient relief sometimes from just the contracture itself. I did have an occasion where I had a lady have a big histamine response where she was red chested. And then once I did her explant, that resolved. That's probably my earliest kind of experience with what we're now going to say is, breast implant illness, which for me is just a really end stage problem with chronic inflammation. The device is one component of chronic inflammation. And your question was like, why now? Obviously, I say you can't outrun a bad diet and you can't pick your parents. So you have a certain genetic capability. So you have genes, and then your phenotype is how they're being expressed. So genetically, people can only detox so much. And your point was like, is everything more toxic? Well, short answer is yes. So the food's worse, the air's worse, and the water's worse. So all those things taken into consideration will give you elevated toxicity with limited detox capability. And you have a device, so your body just can't handle all of that. So now I think it's just more, for lack of better terms, we've tried to contribute as much to the understanding of the problem as we can. Like I said, I've done over 1,800 explants. I understand the genetics behind it, the food sensitivities that people have, especially to things like cruciferous vegetables, impaired sulfur metabolism, um, hormonal imbalance. And then really when you look at a vibrant wellness toxicity test, you'll see all the different mycotoxins that may be they were exposed to. They may have a heavy metal exposure, which I've had patients have that. Things like triclosans, phthalates, parabens, um, perchlorate, whatever. I mean, yes. So the short answer is it's a complicated problem. And that's why, from a provider side, it's very confusing. I think if you go to the GP and you're a female with breast implants or having all these different symptoms, it really is hard for them to navigate. What does it all mean? You have brain fog and you have shortness of breath and you have arthralgias, joint pain, muscle pain, GI problems. Like what? They're like, what is this? This doesn't make a lot of sense. But if you just look at it in the terms of chronic inflammation versus acute. So acute is you go out of your studio, you step off the curb and you twist your ankle swells up, your body sends out signals to cause inflammation, which leads to healing. At some point, those signals are turned off. But in chronic inflammation, the signals are never turned off. So if the device and or other things, toxicity, poor detox from, backed up liver or poor kidney function or bad diet, it's just too much. And then you get the hallmark of basically chronic inflammation.
Amazing. I know this is less popular, but I mean, people do get butt implants. I'm assuming any implant can create this kind of histamine response. Maybe it's mastoactivation. Have you done any butt explants?
I have, but I've actually really narrowed my practice down. And so when you look at polymerase chain reaction DNA analysis of explant specimens, so I take like a thumbnail portion and I send it to a lab and they run a panel of DNA fragments against it. That's a PCR test, just like during the pandemic, everybody, like, you can have an antigen test, a PCR test. So that is a very specific test looking at 150 types of mycobacterium, fungus, and bacteria. The predominant bacteria is Cutibacterium acnes. So that's found in high concentrations on your face, neck, shoulders, and chest. And so that's why it's most commonly associated to me with breast implants. And then the butt implants obviously wouldn't have that because they're by your butt. So it'd be other things like, near the rectum essentially. So I, personally, I have great friends who do wonderful jobs with butts, and I let them take care of the butt.
For sure. Now, can you fix the patient that was sick with just using antifungals, or you're saying there's a microbial issue here? Because when I look at breast implant illness victims, these women that come to me and say, "Hey, I'm suffering." I told you, like we hit before we hit record, like on the organic acids, you'll see all these elevated fungal metabolites. Now, a lot of times we'll see bacterial overgrowth too, and they have all these gut issues. So a lot of times I'm combining antimicrobial antifungal herbs. I'm just wondering, clinically, are you seeing it a fungal majority? Is it a bacterial majority? Is it both every time? What are you seeing?
So only about 5 out of 1,000 for fungal, predominantly bacterial, overwhelmingly bacterial. So what you're seeing is the fungal exposure people are getting. So say for instance, someone comes in from the Gulf or from the coast to me. It's not my job to prove that you don't have job. It's your job as a patient to prove to me that you don't have all, because I assume you have it. And
Yeah.
if you have an impaired glutathione, pathway, then you're going to have more trouble dealing with mold. I think that's pretty common in my patient population. People typically have problems with impaired vitamin D synthesis and absorption, methylation, glutathione, and antioxidant pathways.
Okay. So you're saying these people probably just had pre-existing mold exposure. They were already sick with mold, and then the breast implants just made them worse.
Either or, you have a device and then you get a mold exposure. Typically, you can have mold exposures as a kid. Obviously, I mean, I live in Texas. Everybody's been exposed to mold here.
Yeah.
So, common problem here. It should be thought of, it's very common in Hawaii. It's very common in California. I mean, in any place in California. I mean, you look at it, they're super old. They're on the coast. I mean, the mold's growing on the wall. I mean, I don't think it's that hard to put two and two together for those things.
Yep. Now I see some of the protocol stuff you've put together, like an inflammation support bundle. These are things I use also. So like a liposomal glutathione, liposomal DNK, the calcium D-glucarate, carnitine, liposomal B complex, magnesium, liposomal C. Do you feel like that people can make a full recovery with just supporting all the pathways like that after, or are there other things you do? post explant?
Yeah, so the formulations, I switched to predominantly liposomal where I can, so we avoid pill fatigue, and we have a lot of impaired absorption issues with our patients, particularly ones who are exposed to mold. So that's one tactic to help them get micronutrients and what they need right now. Um, I think in terms of the whole combination is get them started on the correct dietary changes, cut out gluten, cut out dairy, look at their food sensitivities, um, then provide supplements that we know from looking at genetic reports on these patients will really help augment their pathways that, trying to make it more efficient for them will be helpful. And then, coupled to surgery and actually removal, that gives them a pathway to wellness because once you're taking care of them, you'll see that it's very hard to correct the problem with the device in place, especially if they have limited detox capability from just genetics. Now there's a bunch of people who have a breast implant who do fine, but if you just looked at their genetics, you would know why, because they don't have problems with impaired vitamin D synthesis or absorption, or they don't have trouble methylating, or they have a very effective GSTP1 pathway or something like that, and their antioxidant pathway works just fine. So you're not going to become burdened because their ability to detox is much higher than their load, right? We're just like the bucket's full, and you get one more exposure to your point, and that's when you get a patient who becomes, sick. I see people all the time with they were doing fine, and then something happened, a move, a reno, vacation, some stressor in life, whatever. And that's just enough to, tip them over the edge.
Yeah, that makes sense. I mean, we have a good friend who, same thing. She had implants. Luckily, she got them out now, but it was just a lot of family stress. And then all of a sudden, boom, she had them in for years. Everything was fine till the husband got deployed. She's lonely. She's stressed about it, raising kids on her own. And then, boom, got sick from the implants. Got them out, felt way better. Okay, so I see you sell some spore-based probiotics as well. Now, are you doing any kind of antimicrobial protocol, though? Are you implementing either herbal or prescription antibiotics to treat like this bacterial issue after you explant, or you're just thinking you increase the body's capabilities and that's unnecessary?
We're more reliant on the body. And at the time of explant, we go ahead and use a dilute acidic solution to lower the pH in the pocket to sterilize the pocket. I don't proactively put anybody on antibiotics ever because you don't know what you're treating and you're just going to cause more microbiome issues. So we don't do that. Um, if we had a suspicion after surgery or if someone developed a issue, then we would just treat that as a one-to-one, situation. We don't have a program that runs antibiotics after surgery at all. We're more
Okay.
about on reset, and we use cell core for detox.
Okay. Love it. And so when you run these mycotoxin profiles on people, you're thinking that that's just life exposure. You're thinking that's not from the implants, right?
It's not.
Okay.
No, I have plenty of evidence to show it's not from implants.
Amazing. Okay. And when you go and put an implant in, well, I've seen these photos. The body's creating this capsule as a protective mechanism, right? Is that just trying to separate itself from the immune system? Is that what's happening?
Every device that's put in, it doesn't matter what it is, any piece of hardware for an injury, a knee implant, a hip implant, a breast implant, a defibrillator, it doesn't matter, neural stimulator. They all develop a capsule because your body sees it and recognizes it and goes, whoa, this is foreign. So it creates a response around it. And your body's just responding by creating and trying to wall it off and get it out of your system. But unfortunately, things where we get exposed to bacterial or fungal contaminants from whatever reason, somebody could get a cold, somebody could have a urinary tract infection, they could have a colonoscopy and get a biopsy. These bacteria shower the bloodstream, and so you get hematogenous or blood-borne bacteria. And those, if they get onto a device, heart valves, a classic example, people get endocarditis. So it's, basically none of this is new. This has been going on forever. So I feel somewhat when I talk about this, that's the most common way someone gets a biofilm, which is a typically bacterial contaminant on their device.
Okay, yeah, that was the next question. Do you use biofilm busters at all? Are you using nattokinase or serrapeptidase, other like systemic enzymes during this process or after?
And in my experience, after surgery, they're in a particularly sensitive state. So we try to continue on with reducing inflammation and then put them through whatever detoxification protocol works based on their information, the data we collected. And then on a case by case, we add natozymes, cerezymes, whatever we need to add, for that particular patient. I don't try to globally put everybody on that after surgery.
Sure. Okay. What about fertility issues? I mean, have you seen women that are having miscarriages, fertility, any issues with the offspring while they had implants? Do you think that's related?
So we don't have data on, what the offspring are experiencing, but I know there's fertility issues, and so I would just, for not a lack of not, trying to get like into a point where somebody's gonna, throw too many darts at us, but inflammation creates the problems that we're describing. So it doesn't matter what it is. So if we just look at the continuum of inflammation and you have more and more inflammation in your system, your hormones are definitely going to get thrown off by that. The most common hormone we see affected first is the thyroid. I think most people would agree with that. And so, people are like, oh, they put me on thyroid medication. I'm like, well, can you tell the difference? And they're like, no. So as soon as I actually do their explant, I tell everybody the same things. I'm like, okay, you're going to have to pay particular attention to your thyroid medication. And I use that as an example because to me, the thyroid is the most sensitive. If you're on a synthetic thyroid medication and we do your explant, if your inflammation is super high and it's not we don't have a perfect test to tell you like how high is too high. People can experience basically a thyroid storm after surgery because now think of the bioavailability of the medication is much higher than it had been because they had so much inflammation going on. So, and I know that, that's probably hard for most people to understand, but I see it routinely when people get, a response like that. I'm like, you have to be careful with thyroid, especially not so much with like armor or something like that, but I'm a synthetic thyroid medication.
Yeah, that makes total sense. I mean, the gut's probably improving better too. We see that where all of a sudden they have to lower their dose a little bit after working on the gut because
Right.
now
So
they're overdosing.
up, and then now you're seeing like the medicine works, obviously. It's like when someone tells me testosterone doesn't work. I'm like, really? Do you think all the athletes, male and female around the world, jeopardize their entire careers, their legacies, their money, their medals because drugs don't work? No, drugs work just fine. You either don't have the right dose or you don't have the right drug or both.
Yeah. Okay, so women are thinking, okay, what is the alternative? You had a post in April about this. You say that in many cases, women who have breast implants removed, they could greatly benefit from a breast lift. You call this a mastopexy. Is that pronounced correct?
Yeah, there's a few things that we want to do because obviously the initial indication in many instances predominantly was to improve the aesthetics of the breast, either too small or they were sagging or something. So if I'm taking out a device with the caps around it, we want to do it intact, then we want to provide reshaping and lifting of the breast if that's indicated. So wide breast, you want to narrow. And then a breast that's got too much excess skin, you want to reduce the skin and tighten the skin. And then what I do try to do, if we're looking at a size situation that's going to be a big change, we try to add their own fat back to that. And that's called a fat transfer. So those are predominantly what we're looking at in each case. Obviously, we individualize a treatment plan for them to help them either reshape and lift or add volume back or do all the.
Do you find that women sometimes their breasts just naturally come back on their own after they've passed childbearing, they've passed breastfeeding? I mean, in my wife personally, I mean, I see they're getting back to normal before like the pre-kid level. I mean, they're not totally pre-kid, but they're starting to improve on their own.
Well, there's stretching. So there's always three components in it: the skin, the tissue layer, if you will, and the nipple complex. And like, how are those all working together? Now, the changes that you'll see commonly when someone loses or gains weight don't have to do anything, don't have anything to do with the breast tissue. It's the fatty layer. And as we get older, our fatty layer gets thicker, not thinner, right? We'll take away the fact that people are using peptides like Ozempic and the Ulgavi and all these other things right now. So typically our fatty layer gets bigger. So that's why breast will, I try to let people know, like, if it's metabolically happening as you're getting older, where, hormones and our metabolism, they're slowing down and we're putting on weight typically. It's usually in the fatty layer, barring, inflammation and fluid retention. So that's why, like, your wife will have a, not enhancement, but, it'll return to a resting state typically. But when people get super deflated and things like that, that's not so much the breast layer, but that was the fatty layer.
Wow. Yeah. I mean, because post breastfeeding, I mean, they're just gone. It's just like deflated balloons. It's crazy how much it can change. But then it's, almost 2 years post breastfeeding. It's like, okay, they're starting to return to like a pre pregnancy state.
Yeah, so things are more, going to be normalized. The problem is no one's terribly patient during that process. And if it's an explant, then there can be a lot of just such a stark visual change that's really bothersome and concerning. So I try to make sure that we have all of these different options available, but we're super locked in on making sure that when we're doing these, we're looking at toxicity issues and dietary issues and balance of hormones. And we're trying to make sure that we are helping the patients so that in the end game, we're, going to get them to a level of wellness that's, best for each of them.
So this may be a silly question, but do you put in implants anymore?
I haven't for about 3+ years. The thing that I did predominantly, like I said, when I was doing breast cancer reconstruction, I had to solve a lot of problems that were related to cancer. So if an implant had a capsular contracture or malposition or a radiation injury over the tissues, we had to solve for that. So I developed, like many reconstructive surgeons, a lot of ways to solve implant-based issues. And then basically, as I got further on in my career, I never really did a bunch of implant cases. It just wasn't my niche. The thing I did was resolve problems. So if your wife had implants and she had a capsular contracture or a position problem or something like that, she would find me because I did revisions, and then I would help correct it. Now, all of those in the end game develop problems. So finally, I just got tired of taking care of everybody's problems and just stopped doing them. And I just do explants and do the holistic transformations with their own tissue and their fatty tissue. And like you said, skin lifts and breast lifts and, reductions of areolas that are stretched out. So all the things that we can do in a natural way, we help them.
Cool. All right. Well done. Yeah. And I saw photos too of thermography. So you've used thermography as well to kind of look for this and try to prove this on paper. Is that right? You'll take a woman and do a thermograph and say, okay, we see inflammation here. Like you're a good candidate. Or most of these women pretty convinced already and you just go straight for it.
Yeah, I mean, we see a lot of visual evidence of that on thermography. We see a lot of it on laboratory analysis, and then broadly looking at it with how they detox, what exposures they may or may not have had, their food sensitivities, their hormonal imbalances, their GI maps. I mean, it's more of a collective rather than an individual. We also do a lot with hyperbaric oxygen therapy in the office and lymphatic massage.
Cool. Okay. Yeah. I love the GI map. I run more of those than almost anybody in the US. Now, that bacteria you said, though, that primarily is found, that's not tested on the GI map, right?
It's not, and we don't do biome FX. It's a bit too much for this. We're trying to get it turned around so we can make as much impact as quickly as possible. We want to get all of this turned around, and those studies sometimes can take 3 to 8 weeks. If you just listen to what I said, that's a lot of information to turn around, get results, get we have a practitioner, a detox practitioner on my staff now because I don't have enough time to do it myself anymore. So it's still a lot to turn around and get on, a call and set up a plan and get started on a plan and help them prior to surgery, then have surgery, then, get back into the plan once surgery and its recovery has gone to a point where you can do that.
Is what would be the one go-to test? I mean, I know you could do organic acids, you could do mycotoxin, you could do the chemical profiles. If you have a woman who's like, hey, feel terrible, have implants, like to look into this, what if you could only use one test, what would you choose?
I know most that are genetics now by just listening. So I would do
Yeah.
their to me.
Say that one more time.
tox test, the total tox,
Total tox. Okay.
picture of like what, potential exposure there are. And it's not anything you can listen to and know in my experience. I mean, I can't tell you that your wife had a triclosan exposure because she used the organic wet wipe that had it in, she absorbed it. So, and neither could anybody else as as much as I've seen and as much as I know. Every time I get one of those tests and there's some other like unusual finding, I'm like, I would have never came up with this. I mean, it's not possible. So that it's you don't know what you don't know.
Yeah. I see it in kids too, kids that are just off the charts with stuff. Now, if you were choosing just the tox test, are you saying that just because the clue of, say, xylene and benzene and gasoline additives and car exhaust and all this stuff, you're using that data to show how poorly they detox? Is that why you would pick that one?
I think it helps on the back end. So if someone comes in and they're not doing, great at 90 days or great at 6 months or what have you, and say they chose like, all right, I don't want to do, detox. I'm just gonna see what happens. I'll have, people do that. But if you come in and you're super symptomatic after, 2, 3 months, I just pull that test up. I'm like, well, these are things just like you mentioned, like somebody may have been in the military and had jet fuel around them all the time. I mean, that's a neurologic disruptor. So, do you still have brain fog? Yeah. I mean, do you not feel well? Yeah, because it affects your hormones and your neuroendocrine system. So I think, my point is like just doing explants alone is not going to resolve the kind of multi-layered issue that you're experiencing with chronic inflammation. So if you don't know the drivers, I don't really know where you're going to go at the end.
Understood. So when you're talking 90 days, 6 months, you're saying post explant, if you're checking in, they still feel like garbage. Okay. Amazing. Well, anything else you think people should know about implants? It sounds like you shouldn't need them. They could possibly be avoided by doing some of this fat transfer technique, some of the lifting you're describing, some of the skin tightening you're describing.
Well, I think everybody asks me like, oh, would you let your daughter get, breast implants? I have a 15-year-old daughter. I'll just say it this way. So uh, I would tell her exactly, what I understand about her genetics because I know her genetics. So even if I didn't, I would say, look, these are the things that say you had to get a knee replacement or hip replacement, or you had breast cancer and you had to have mastectomies and a reconstruction. These are the considerations. So the problem is not that, you know, are they or did they not serve a purpose? Because yeah, they're going to be continued use of devices. I mean, knees, hips, breast implants are going to get continued to be used. It's more about like just having the discussion. These are the risks and benefits. This is what you can anticipate, and this is what to pay attention for. I think that's all patients really want to know, and they can make their informed decision with you. It's just you know when someone makes a request of me to explain this to them, it's incumbent on me to do it to the best of my ability. And I have a lot of information to be able to explain it in a way that helps them make a better decision.
Yeah, well said. Okay, I know this isn't your specialty, but I want to ask about it because who else has as much experience as you in this? Not many. The question of knee implants. So you're saying that someone could literally have like a knee implant illness as well?
Chronic infections with hips and knees is as old as they've been around. I mean, any implant, it doesn't really matter. There's plenty of examples in the literature about this same bacteria, Cutibacterium acnes, infecting like shoulder implants. And so I think biofilm, if you just want to generically say biofilm, and for the sake of this discussion, is basically bacterial contaminants around a device. And I've seen it on, blood vessel grafts, hip implants, knee implants, breast implants. I don't do dentistry, but I used to repair broken jaws. It can happen there. Um, I've taken out infected neurologic stuff, spinal hardware, whatever. I mean, I've helped everybody take care of these types of problems. So if you're putting something in that's not yours, it's got a chance to become infected. It's higher than obviously if you're doing your own tissue because it's not your DNA, it's not your genetic material. So I think we just have to accept like if you're doing these things, there's a risk that goes along with it. And
Yeah.
and who need hips and knees and breast implants and dental implants, neurologic implants. They just need to understand the risks so they can, make an informed decision. And there's not a lot of, situations. I did cancer reconstruction where people were going to lose a limb or they're going to, potentially go flat and that was fine if that was their choice. So those are all the decisions. These are not easy decisions people make.
Yeah. So like if you're 75, you've already had the knee replacement, you're just trying to improve quality of life. I mean, I wonder if just keeping someone on or rotating in like some herbal antimicrobials that aren't going to really damage the microbiome in the same way antibiotics would. I wonder if that'd be a good strategy, because it sounds like over time, systemically, these people are somewhat getting poisoned by these endotoxins produced by these bacteria, right? They're walking around with this load of bacteria around this knee, for example. Isn't that going to weaken them over time?
It's about 30% of the patients I've taken care of with breast implants have had a biofilm. So that's one, roughly one third. It's not everybody. And, there's not just this perfect way to analyze that from a lab test to tell you. So I look at that broad picture, like I said, and we have a urine metabolite test for thromboxane A2 that came out of the pandemic. We have the other aforementioned, a GI map, a food sensitivity test. You're looking at hormones, you're looking at a tox test that's urine based, and you're looking at their genetics. I mean, that's a non-allopathic way to look at this problem, except for hormones.
Yeah. Yeah, because I'm thinking if you're hearing this, you're like, well, crap, I can't get my knee replacement out. Like I've already done it. I've got this implant in the knee. I don't want to cut my leg off. I don't want to go on crutches or something crazy. What do I do? It sounds like you're saying just build up the host. Try to increase the resilience of the host if you have to keep something in like a knee implant, right? I mean, you can't just pop that out and do something different, can you?
Trying to augment their basically immune system by vitamin D synthesis and absorption, methylation, glutathione, and antioxidants. So that's why the inflammation support bundle is basically based on genetic results. It's not, I didn't sit down with you at a bar someday and just like randomly come up with that. So that's to help with that. And then they would need yourself or another holistic provider to help with any kind of herbs or anything else specific to help augment that strategy. But those are the things, from a you know, biochemistry standpoint that would help you. And then
Yeah.
anything helps the gut brain axis or the gall, which is your gut associated lymphatic tissue, anything that will help that system is going to help you long term, as well as lymphatic drainage and eating a proper diet and just lowering baseline inflammation with better air quality, water quality, food quality.
Love it. Okay. How about stem cells? I mean, can you get the stuff you need? I mean, you always hear people discuss stem cells and they say, well, you can't get the good stuff in America. You got to go to Mexico or whatever. What can you access? And then what actually works, or how do you implement that?
Yeah, we do same day stem cell therapy with adipose derived stem cells from fat. We take fat and we have a device to go ahead and curate the cells from. So that works. There's other technology called V cell, which is more embryonic stem cell therapy that comes from blood. You activate it with a laser. But you're talking about the others where you have to go down out of the country because it's not approved in this country to be used. So I think over time we're going to do our country's a bit slower for good reason about these therapies. Um, I think, I'm comfortable with any adipose derived stem cell therapy. That was my research when I was in teaching, and I've done thousands of fat transfers. It's, that's what I do. I kind of move fat around and I take care of the skin, and that's my, domain essentially.
Amazing. Okay. Yeah. So these are also called MSCs,
Mesenchymal stem cells.
mesenchymal stem cells. Okay. And these are from your fat. And then where do you put those and how do you implement those clinically?
Yeah, so you can give them back IV or you can give them back topically or aerosolized. I have a facelifting technique where it's called the no cut facelift, where we use a device that removes skin without take and leaving a scar, and we topically apply it at the end of the treatment. So with that technique, when you used by us, we can use it to remove about 1 to 1.5 inches of skin from your face at one time without any visible scar.
Wow. Do you use stem cells personally? Cool. Is that did you have an injury type thing? Is it anti-aging, or
For 25 years.
say that again?
operating for over 25 years. It's more of just the wear and tear on my body. So.
Yeah, understood. How about peptides? Do you use or implement peptides at all?
Wow, I've used just about everyone available. I always try to make sure I have a complete understanding of something before I recommend it to someone like yourself, your wife. Prior to things being pulled, we used a lot of BPC 157. But we have, I think from a user standpoint, I try to be a little bit more selective and concentrate on those baseline elements that we discuss with nutrition, supplementation, water quality, air quality prior to making a leap to peptides, because the more you ask someone to do, the lower the compliance. So I try to keep it straightforward. But we have availability for things, and in our patient population, if I have somebody who goes through explant, still has weight issues or something like that, we can microdose semaglutide. We're very familiar with GPL-1 inhibitors in our practice. So it's more about tailoring it for the specific person. I don't have a big funnel that drops everybody in to just do that program because our niche is so specific. We're just trying to make sure that we get patients of ours to their version of wellness, whatever that looks like for them, so they can feel the best and go out and just be productive with themselves, their families, their friends, and live the highest quality of life they can.
Agreed. Okay, and this is a little geeky, but people that have listened to the end, they're probably a little more geeky. So what about TB 500? Do you know anything? Have you used it? Any benefits you've seen?
Haven't used.
Okay, or TB4, you'll see it as TB4 sometime, the thymosin beta 4.
They so the other thymosins, they pulled several of them from us, and we haven't revisited those when they were pulled. I try to always, if we can, make sure that we're like um, at least from an information basis, trying to analyze it and provide the best information to the client. So I try to make sure I have experience first, and then the team does, so that we can just provide feedback and make sure there's not going to be some kind of you know experience issue for them that we couldn't guide them on best. So I don't have with that enough experience to comment.
No problem at all. All right. Well, we have your website, breast implant illness expert.com, drrobsolutions.com. Any other things you want to leave us with, tell us with, wisdom, pep talk, anything else we should hear?
Well, I think, as well as our YouTube channel, Breast Implant Illness Expert, we're just trying to provide quality information. So I'm not into fear mongering, which happens on a lot of social media sites and in the internet in general with a lot of negative experiences. I feel like we've provided a very logical, well thought out approach to a very complicated problem. And it's taken me about 7+ years to figure out what I do right now. And we're always trying to improve it. I have a book coming out next year about our surgical recovery program. And so that will help patients who can't access us. We run our detox programs for patients who can't have surgery here. So that can be ran remotely to help them. And we have a lot of experience because we find patients who detox too quickly get Herx types reactions, and we know how to do that effectively. So we don't want to have patients experience that problem. So they can come visit us for that as well through my HARP program.
Awesome. Ballpark price to get explants out.
Oh, ballpark price. I think it's going to be it depends on how long you stay here, around 20.
20,000. Okay. And how long you stay, meaning the pre-care, detox support, post-care?
Yeah, people stay in Austin about a week. Just because I have there's not many offices like mine that have a lymphatic masseuse, the German lymphatic device Balancer Pro, a hyperbaric oxygen therapy chamber, uh, you know, IV therapy. You know, I, I don't know who else has all that to provide that in the time after surgery. It just makes it easier if you're here. So a lot of people want to get, home as quickly as you can, but then they'll, bring us up. Oh, I can't find a lymphatic person who's trained, or I can't access the lymphatic device, or there's nobody with a hyperbaric, or that I need a prescription, or there's all this stuff. I have a vertical chamber so people just sit in it. They don't have to crawl in it. So, I mean, there's a lot of thought put into what we have and what we've curated. A lot of patients, I try to make it easy if they're bringing a caregiver. We have non-invasive skin tightening, so we'll have them get a soft wave treatment or a facial or something. We try to make it as easy as possible. I know it's hard to just come and hang out, but I feel like if surgery goes well, which in my hands it does predominantly go well, a lot of experience, it's really the aftercare process. As long as it started and gets off to the right, I like to say cadence a lot, but from our program, if you get started on the right track, we don't have a lot of people fall out and become outliers. So, you're going to go on if you can keep your diet on point and you can, from a protein perspective. So I'm a big, dietary protein person. So my patients who have the most difficult time are vegans because they don't typically take in a lot of protein. So like our protein in our office is all pea based, which doesn't taste great, but it's vegan. Um, you can have shakes and or supplements are here, but like once you get home, you got to keep that up, and people just fall out from. They get back to the routine, which is not really about self care. It's about it's just about get through the day. What do I got to do to take care of the house, the kids, the dogs, whatever the the work schedule is. That's why I like if you spend enough time here, I feel like I'll have you in a good situation when you go home.
I love it. No, I'm totally in agreement. I used to live in Austin a decade ago, so if I get back down there, I'll come shake your hand. Maybe we could record a video in office sometime.
That'd be great. Everybody comes there. Everybody's, you're one of the few people left.
Yep, I know. I was there 2013 and 2015. I left. It was already getting crazy in 2015, so I can't imagine what it's like now, almost a decade later.
It's quite a bit different.
Gosh. All right. Well, I'll let you go. Get back to it. Thank you so much. You're listening to Dr. Robert Whitfield, and this is Evan Brand signing out. Thank you all so much. Take care.